with the introductions. My assumption is more people will come in as we go along. It gives me incredible pleasure to introduce the speakers for today. I do want to point out that this talk today came out of, oddly enough, a talk at a bar at like a CORD meeting when we were talking about what is it that motivates the group that is coming to us now as residents versus what is it that motivated us about the field when we joined it. So I am super excited to introduce my fellow gray hairs. Dr. Thomas Perera is program director at North Shore LIJ, Zucker, Northwell, pick any of those names. It fits together. He's in charge of that. Andy Ulrich, who is up at Yale, a small school in Connecticut, some of you may have heard of. Dr. Carter is, as far as I understand, pretty much emperor at NYP, or emperor emeritus, or something along those lines. Between them, they have an enormous amount of time invested in emergency medicine education, have clearly seen a couple of generations go through. And I think that in reflection upon what has happened with the match the last few years, we were coming forth with some ideas of what is it that we really do as emergency physicians, and what is it that we should be explaining to the incoming generation. And with that, I will turn it over to, I'm sure, an incredibly structured and precise discussion between these esteemed gentlemen.
Yeah, Mary, can you
I'll monitor the chat bar, or I suspect they'll be fine if you want to chime in with questions as you go along. Gentlemen.
We've got lots of slides. You want to
share our
slides?
Oh yeah, we're gonna flip up those slides in about an hour after the thing is done. When I read the title of this, when I figured out what we were talking about, which is what is the reason to go in emergency medicine, helping students realign their expectations of the specialty, and with an expert of it isn't lifestyle, I realized I think we took our eye off the ball. We as a specialty were top of the heap for a long time. We had the pick of the smartest, the best students, and we were able to sell ourselves in a way that over the last 3 years has changed. And this talk, I think it's really important to have, because the one thing we as a specialty can't do is allow other people to choose the narrative for us. We need to be the ones out there, and that does mean reaching out to your medical schools. That does mean getting involved nationally as a voice to be the narrative of emergency medicine and what it is and why we went into the field. And when we started to talk about this, the first thing we said was, okay, why did we go into emergency medicine, and has any of that really changed over time? What do you guys think?
Well, I think you bring a great point. I think, first of all, we all acknowledge, and I think it's real, that the last 3-4 years has been incredibly disruptive. And part of that is self-inflicted as a specialty, because we were very vocal and have been very vocal appropriately about the difficulties that emergency departments are faced with and what we're asked to do in healthcare. And I think we've done a great job of escalating and highlighting problems. I think where you're absolutely right is we lost sight of sometimes we lost sight of the fact that our audience was also medical students and people starting to start their careers. And we were very, very openly acknowledging that things were really difficult, and COVID led to that, a number of other things as well. And I think we have to refocus on how we're presenting ourselves as a specialty, and really put forward the positives. Okay. We haven't done a great job of in the last few years of doing that. And I think it's
go back to the beginning. What made you, Andy, go into emergency medicine?
So I think, we all have our own different reasons, right? We all, we find what fits. And in my journey is, it took me a while, longer than most people, but I actually found
Some
what,
people like to stop off in the minor leagues.
Yeah,
In your
well,
case, the
I made,
actual minor leagues.
I made camp there for a while. But I actually found what fit. I found what fit my interests, my skill set, what I was good at, what I wasn't good at. And within the world of medicine, this is what fit me. It was my interest. I was able to focus on the things I enjoyed, and I was able to avoid the things I didn't enjoy. And I think part of the expectations, or part of the opportunities for students coming through, is to figure out which field out there fits them. And there may not be it's not always an easy answer, but I think figuring out where you fit as a specialty is critically important.
And Wally, did you just come out of the womb into emergency medicine, or was there more of a journey than that?
I mean, for me, it was, and I think it's different, I think there are generational differences to why we went into emergency medicine when I started. When I went and started emergency medicine, I was in the third class of paramedics in New York City. I was at Jacobi, which was kind of one of the first programs in the country. It had the first residencies one of the first residencies in the country. Pre-penicillin, myself and Pasteur. But I kind of was in emergency medicine, and despite that, being deeply involved in emergency medicine and loving EM and EMS, I still kind of strayed off the path and headed to general surgery, and then realized that, at the end of the day, being in the OR was the most fun you could have with your clothes on. But I also really missed seeing kids. I really missed seeing wild and crazy patients. I loved seeing all the things that I couldn't see. And I came back to emergency medicine, and I think it was different because it was smaller. And I don't think we were kind of like looking for our identity. And I think everybody felt that they were a little bit of a pioneer. But I think, to your point, Tom, I think over the last couple of years, I think we did what coaches will always tell their athletes never to do: never read your press clippings. And I think we started to say, okay, we went from nobody wanted to do emergency medicine. We were the renegades, we were the outcasts, we were the outlaws, and we wore that, badge proudly. And now all of a sudden, we just assume that the students who are coming into emergency medicine have seen the evolution of emergency medicine and realize what an incredible field it is. And I mean, how different it is over the last 15 years, where before, academic departments were few and far between. Now, academic departments are everywhere. Deans of medical schools, CMOs, COOs, CEOs, NIH, CDC, all being led by emergency medicine. And I think we came to an assumption that because we lived through that and we saw it, that the students and everybody else behind us knew it. And we didn't let folks know that this is a very different specialty, that you get all of the benefits of every day walking into a shift and saying, today, I could save somebody's life. Honestly, I swear to God, I could save somebody's life, or I can make people's life better by just being here in the emergency department. And it's an incredibly joyful and joyous experience. But then more importantly, beyond that, the world is your oyster. I mean, you can do research, you can do academics, you can do healthcare leadership. I mean, I think that's what we have to get the students to understand, is that the basic joy of sitting at standing at the bedside next to the patient, which is so much fun, is still there. But we have things that no other specialty has.
So
and I think we need to bring that back.
I think you've hit on two of the points that I would hope we were going to get to. The first is that if you look at our lives from outside, they fit really nicely on a t-shirt. So the idea that you have a t-shirt that says, I can save a life. Yeah, there you go. I can save a life before I finish my cup of coffee in the morning. People still respond to that. The students, and we talk about generational differences and things like that, they're still going to respond to the fact that I can make a difference. What you just said, I can make a difference in somebody's life every single day. And that should be a focus that we never move away from, because that is us. The other thing you said that I thought was great, and was something Andy had talked about before, was that it's a broader field than people give us credit for.
Right.
Marianne is actually the person that I use as the example of this, that goes through part of their career doing one thing, research and all that, and then at some point just say, okay, and switch entire areas within emergency medicine, switch hospitals, and reinvent yourself to prevent that sort of mid-career doldrums. And not every career do you get to reinvent yourself like that.
So yeah, I agree 100%, Tom. And I think it goes back to picking what fits, right? And I think, you know, the desire goes along with the ability to reinvent yourself. And there's an aspect of that, a personality aspect of that, which belongs in a certain field, and that's emergency medicine.
Yeah.
Every day's a little different. Everything's a little bit different. And you can create different things for yourselves all the time. And I think that's what makes this field the perfect field for the right person. And, you know, going back to the initial question, that's what brought me to the field, because boredom is a 4-letter word for me. And I was so afraid of being
You really
bored.
can't spell, can you?
I can't, no. And so I realized this allowed me to do something different. And I, like Marianne, I've, repainted my stripes many times through my career, many different places. And, I think about us as bushes with wide but shallow roots. Is you can pick it up and replant it somewhere else, and it's going to very quickly grow and get stronger. And that's unique to emergency medicine. Most fields get very narrow, deep roots, and you can't uproot and be successful quickly somewhere else.
Yeah, I mean, I think this.
I just want to jump with one other level of thought here, and that is the skill set that we develop both through the residency and through the career is kind of following up on what Andy's saying. What do we have to develop? We have to develop becoming incredible communicators, because you have to communicate with every specialty in the world in their language. So we translate, we communicate, we develop bedside skills that other physicians just don't have the opportunity to do. They just don't have the opportunity because they already have the CAT scan, or they already have the echo, or they have whatever it is. Just those two skills alone allow you to literally pick whatever this bush is up and bring it over to travel medicine somewhere else. But I think we've emphasized the concept of it gives you the opportunity to travel and do other things, but that communication skill is a huge thing. I'm looking at Lara, who is now the chair of the department. You served as chair of the department, Andy. And I'm looking at our institution where we have people who are CMOs, almost a lot of them from emergency medicine. And why is that? Because of the communication skill set that we're required to develop as well.
Well, I mean, I think of all, you think about it. What's the one skill in emergency medicine? Somebody, we talked about this at the American Board of Emergency Medicine, for certification process. What's the one skill that every physician, EM physician uses with every patient? It's not a cricothyrotomy, it's not a thoracotomy, it's not a thoracostomy, it's not a lateral scanthotomy, it's communication. And we are tasked, which I think is one of the greatest challenges, and I think one of the most unique and enjoyable parts of the specialty, is we've got 30 seconds with a patient that we've never met before to gain their trust and have them believe that we are going to be their advocate and we will not let them fall off the rails. Everybody knows who's going to do their colonoscopy tomorrow. Everybody knows who's going to do their cath tomorrow. But you come in the ER door and you have to make that connection. I think that is a skill that allows you to, as you said, Marianne, if you can make a connection with a family member whose husband or wife or son or daughter, whoever it is critically injured and dying, and you can make a connection with that patient and then let the family know that you're there and you're going to be there for them, then, negotiating a contract as the CMO or, whatever, that's child's play. And that's why we're so good at it. We force ourselves, because of where we live, we have to deal with everyone. And I think that's one of the beauties of the specialty. And I think students and people coming in should realize that it's not a skill to be taken lightly. It may be the most important part of the secret sauce. Which is, I think, again, at our place, what's interesting is, half the C-suite at New York Presbyterian is emergency medicine. And what's really interesting in our place, we have a differentiation between the medical school and the hospital. And the medical schools hold the clinical appointments. almost everybody who goes into the C-suite at Presbyterian who is not an emergency medicine doc, the first day they walk in the door is they give up their clinical privileges. I don't want to go back to the OR. I don't want to go back to the clinic. Almost all of our EM trained folks who are see something all see patients in the ER. And I think that says something about what we stand for and who we are and where we actually find our most enjoyable and joyous moments. And it's in the emergency department with our patients. And everything else we do afterwards is gravy. And the problem is if you're a vascular surgeon, look, you backhand, you forehand, you square knot, you do this, you put in Dacron, you do, I mean, it's the same thing every time. And there's a certain amount of repetitive, which by the way, muscle memory is important for a surgeon, and I get it. But our days are different. And then when we're finished doing the place that we're the happiest in, we get to do things that then play to our strengths, which most other specialties don't. And I'm not sure that we bring that forth when we're talking to the folks that are thinking about why emergency medicine. It's like, well, where do you want to go? I mean, what do you want to do? There's no point, there's no place in medicine that you can say doesn't intersect at some point in time in the emergency department. We are the virtual reality Venn diagram.
So I think that speaks to the complexity part of our field. It is, they always talk about career satisfaction, or at least, Gladwell was one of the people who did this, but as having autonomy. And when you're in the emergency department, not necessarily as a resident, but when you're in there as an attending, you actually have an immense amount of autonomy, complexity, so that your job isn't repetitive, but allows you to keep growing. And medicine, emergency medicine, is wonderful. Marianne, again, is one of those people who will say, I've never seen this diagnosis before, and I learned a ton today. And being able to talk about that stuff out loud as something that is positive, instead of the medical student's perspective, which is, I want to be the doc who knows everything. Well, that would be boring as hell. I want to be the doc who continues to learn throughout their career and sees things throughout their career that I find interesting. And our job has that. And that's a huge plus to push. And the last is this connection between the amount of effort you put in and the amount of reward you get. And reward, of course, is whatever you want it to be. Clearly, a simple answer is the more shifts you do, the more money you make. But it really is usually the more time you spent sitting with that patient who was angry, belligerent, and turning them around so that you can give them the therapy they need, just as satisfying. So I think our job has all the elements of true career satisfaction.
But the problem, Tom, is that to your point before, is by allowing others to control our narrative, all the backdrop about burnout, all the backdrop about boarding, that ridiculous ACEP paper on the workforce, which is just absolutely crap. The students don't, they hear that narrative, and that's what allows them to not, to kind of, not see the forest from the trees. They see that they walk through into the ER and they get poked in the eye with burnout, boarding, this, that, but we never get a chance to show them the whole forest. I think we need to do a better job and say, I was speaking to an endocrinologist the other day who does, she was telling me, she said, I think I want to quit. And I'm like, why? She goes, well, I'm an endocrinologist. I do mostly obesity. And she said, I'm really good at it, and I do a lot of research on it. She said, I spend probably 10 to 12 to 13 hours a week on the phone with the insurance companies trying to get people to get them Zepbound or Mounjaro. And he said, by the way, it's not for weight loss. I'm taking people who are losing 40 pounds and their blood pressure gets better, their cholesterol. I'm saving people's lives, but I'm spending more than half of my week on the phone arguing about patients. I don't want to do this anymore. Well, that's burnout. And the answer is we sometimes we own it in the emergency department. It's the same everywhere. We got to shift the focus from these 2 or 3 or 4 things that other people keep poking us about and say, yeah, that's fine, but that's across the board. But we're going to deal with it. We never give up. And more importantly, we have all these other things, all the things you talked about before, that make this an incredibly impressive, impactful specialty where you can go until you want to stop practicing. You can keep work. I mean, you can't be a pediatric neurosurgeon, much beyond 60 when you start to get that benign tremor. You can't do that. you can have a benign tremor in emergency medicine and practice for a while because for all sorts of reasons. But I think that's the message, and like you said, one of the things about this title was, it's not lifestyle. It's not lifestyle. It's not lifestyle in that we're trying to get away from work. We're trying to craft.
In lifestyle, I think lifestyle is a good segue. Again, going back to what drove me to the field and what brought me to the field, one of the things, and it's cliche, but one of the things was really, I always felt like I could go home, look in the mirror and say, I'm part of the solution, not part of the problem of healthcare. And I think that's what we need to continue to message.
So that is something I've been proud of about being an emergency physician since the beginning. I don't ask people what their insurance are.
Correct.
It may take them 5 hours to get to me from the waiting room, but if I see them, they're mine, and I'm going to take the best care I possibly can of them.
And I think to build on that, which is not only has that always been part of it, but I think where we are today,
More important
looking
than ever.
forward, it is going to be even more so important that we as a specialty, people coming into the field, are going to be given the opportunity to help drive change in our health system. Because it's going to come from the emergency departments, because we are the ones who are going to be tasked with fixing access. And to me, if I was picking a field today, I would even more so than I did 35 years ago say,
the first half of the career.
Yeah, the first half. I would even more than ever say, this is what I want to do because I want to help fix this. And nobody else is going to be in a position to fix this like we are.
I mean,
I think adding to one of the things that Tom said before in terms of what makes a successful career, I think having an underlying sense of mission is something that also clearly has sustained all of us. And the reality is, as you're touching on now, not having to deal with the insurance companies in as direct a way in any way, shape, or form, allows us to continue that mission to serve the Stinky Feet Club, as we call them, or the people who are in real need, the guy who happened to do some heroin in my emergency department the other day. Whoops, how did that happen? But still, it was about how do we help him? How do we help guide him after that? What can we do for him? And this field allows us both advocacy in both small and large ways, either for that individual patient or frankly for healthcare in general, as you're saying, as well as allows us that personal sense of mission, walk in, come out at the end of the day, know you did something good for someone, at least one person.
I think the question really should be, why aren't more students interested in the field? And I think it says a lot about what Wally's gotten to, which is the message that we've allowed to go out there has been negative. And we have to figure out how to change that message.
So I went into emergency medicine. I'm a pretty simple person deep down. And I walked downstairs and all the people that I dealt with in the emergency room were smiling. And
patients or
no, the patients not so much, but the doctors were smiling. And actually, I don't remember the patients not smiling, but and I do think that one of the things that the fear around COVID for 2 years made it so that medical students that would normally wander downstairs did not. So they again were stuck with other people's narrative of us, or our face was behind a mask and you couldn't see that I was smiling. I guess I could have drawn one on the outside.
We can see you smiling whether you have a full hood on. We can always tell you.
I think that now that we aren't necessarily wearing masks all the time, it will help us. I do think that we need to reach out to the medical students early and have them meet us, see us in our natural environment. And that is always done more to sell the emergency department than a lot of other things, because I don't think that message has changed upstairs. When I was coming through, it was, you're a jack of all trades, you're going to burn out, you never follow anybody up. That was told to them 100 times, but then they would come downstairs and meet me, and they're like, wait a minute, this doesn't sound like what's been sold to me.
Yeah. And I think, I think we also need to be very careful that, unfortunately, very early on, our exposure and our interaction with medical students is very episodic, and it's kind of a snapshot, right? So I think we had to be very careful. And again, emergency medicine, emergency medicine docs by definition, we're demonstrative, right? We emote quickly, we get angry quickly, we get unhappy, we get happy quickly. I think we need to be very clear that when the students are coming down and the place is on fire and there's borders everywhere, and it's okay for us to bitch and moan about it, but I think we need to educate the students saying, look, here's the deal. We're not, we're unhappy about this because it really changes our ability to care for our patients who we care deeply about. That's what we're upset about. We're upset about this poor person has to live in a stretcher for 24 hours. But I think you have to let them know that this is not something that takes away from the joy of emergency medicine. It's just, it is the reality of who we are in 2024 and 2025 and 2026. But I think we just have to be a little bit more mindful of our conversations to let the students know that it's not all negative. There's a good side. There's so many parts beyond the boarding, beyond this. And I think otherwise they walk in, they say, oh my God, the attending was upset and he was angry or she was angry or whatever. And they do not look happy and they walk away. I think we need to make sure that they understand that there's two sides to the coin.
Yeah.
And I think that's really incredibly important for us.
Yeah. I think, we are experts at navigating the system. We all have dysfunctional systems to varying degrees, and it's so challenging for our patients of all classes to navigate things. It's our job to help navigate them through. What kind of care do they need? What specialists do they need to see? What kind of imaging do they need? That's not going to happen in the primary care office nearly as quickly. And, it's our job to be experts at that. And I think we really are. And the other thing I tell the students and all our residents, and I give the same talk, to the new interns coming in every year, we have the opportunity to meet so many cool people. Some of our patients are so amazing. You meet people that have done so many amazing things. I met a guy a few years ago that came in, he was wearing dog tags. This guy was in his early 90s. And it turns out he had served with General Patton in one of his tank divisions in World War II. So it's like, I pulled up a chair and talked to the guy for 15 minutes. It was unbelievable.
It's all part of it's the beauty. It's the beauty.
Oh, it's the beauty of the specialty. I took care. Yeah. So I'm originally from New York City. Both my parents are born and raised in Staten Island. So I've been a lifelong Yankees fan.
Yeah.
So yeah, good and bad. And so, I'm in Peoria, Illinois, the middle of the Midwest, right? So I see a guy, this is last year, 90, wearing a Yankees stocking cap. And it's like, and he comes in for altered mental status with his family. And so the resident staff, so I'm going to go and see the guy, say, hey, are you a Yankees fan? And he goes, fan, hell, I played for him. And I'm like, this guy is so out of it. And so I Googled the guy, and sure as hell, he pitched for the Yankees for 3 years in the late 50s. He did pitch for the Bradley University team here. And it's like, holy crap. So I go back and talk to the guy. I mean, it was unbelievable. So but that kind of stuff happens all the time. And just, you go home so jazzed, I mean, granted, we see a lot of other cool things. We get to make amazing diagnoses and all this cool stuff, but the connections we make with people are so cool. And I think we don't necessarily do a good job stressing that with medical students.
I go to so many of the, the cord meetings, and I go to all of the medical student meetings, and I listen to folks across the country. And I'm always kind of, a little taken aback in that all those things we just talked about don't get brought out.
Yeah.
They become very sterile. They become very technical, very data driven, very this. And I think that I think we probably have to relieve ourselves the responsibility of trying to, fake that we are really physician scientists. And they, we're kind of, and again, generational reference, we are the MacGyvers. I look at the residents, they say, well, who's MacGyver?
What's a MacGyver? No, what's a MacGyver?
What's a MacGyver? It's a penknife that becomes, a shotgun or something.
Yeah, right.
But I think that when we talk to the medical students, I think, we got to be all about the great part about emergency medicine and the research and this and that. But I think we also need to bring home the other part that makes this specialty so damn interesting and exciting, like you just said, talking to your patients and hearing patients and getting a chance to, work with the same group of nurses every day, the same techs every day, and kind of having no matter what happens comes through that door, come hell or high water, we're going to come together as a team and we're going to figure it out, and we're going to make it work. That is something, when you come into work every day and that's who that's your team.
Yeah.
I think the one thing is the thing I remember over research over the years and years and years and years. So the one thing about how do you predict a successful applicant, and it wasn't outstandingly perfect research. Don't tell Steve Hayden that, but Steve Hayden looked at applicants, and one of the greatest predictors of success in emergency medicine was the concept of, were you ever a part of a team, and do you want to be part of a team? And if you're a rugged individualist, then dermatology is probably where you want to go. But if you want to be part of a team and have a team and everybody's got a different skill set, man, and I think these are the things that the first and second year medical students need to hear beyond, oh, you can do research, you can do this. They need to hear that there's another whole part of the spectrum of the process, which is cool.
Yeah, but I think what's really interesting, and this really has come forward this week. We're at a meeting where the keynote speaker was really talking about generations and how they look at life differently and how they sort of come forward differently. And I think what you just said is absolutely a key component of this, which is, I don't know if what was important to us
Is important to them.
is important to them.
Not
And I
important.
think that's how we have to start thinking differently, which is, what is it that's important to this next generation that we have, that we can say, look, this is what you're going to get from emergency medicine. And again, this was a big conversation for the last couple of days where we are, and not to be judgmental. Once you say that, you're being judgmental, but this is much more of a me generation. It's much more, what is about this that I will garner from it? And I think one of the things we have to do is to start putting forward more about, this is what you will get from this, maybe less of what you will give to it.
Right. And so at this meeting that Andy and I are at, this woman who did, the Gentelligence, and she said, you have to kind of go to this, the residents and the students and say, when they present a patient, to say, okay, well, this is what I would do. And it's almost like you have to say to them, well, how would you approach this? And I think there may be something in that where, the generation that has a sense of, what's the specialty going to do for me? I think we can say with a relatively large dose of assurance that you can ask a student, what is it? How would you approach this? And what do you want out of emergency medicine?
Right.
And I think it would be hard pressed to find a student who's going to tell you, I want to do X, Y, and Z, that we're not going to be able to look them in the eye and say, you can get that in emergency medicine. You can't get that in specialty X. You can't get that in specialty Y. But emergency medicine, you can get that. What do you want out
Tie
of
that
it?
into,
We can give it to you.
I want to tie that into the conversation, the tagline about lifestyle, because, back when Tom and I got in, when they were letting anybody in, shortly thereafter, the program ER became very popular. And there were a large group of people that were drawn into the specialty. And there was also the keyword, and we're going back to the concept of lifestyle, because hypothetically, that generation of physicians heard that they could have a great lifestyle in emergency medicine. What was that code for? That was code for working 3 shifts a week, and then you go take care of your life, your family, whatever else, and you're not engaged or involved necessarily in the hospital or the system, or however you want to term it, that you could come do your time and leave. And I think that's one of the ideas that we have to blow up, because the people who are doing that are the people who end up unhappy often. They are the people that are often depending on what their alternative activities are, because the reality is, in the midst of COVID, when we were having a real tough time with, taking care of people, and it was all real hard, we were also in a position where I was working with people that I'd worked with for 30 years. And so you had a connection to people, you had time to kind of blow off steam about what was going on. If you're coming in doing 3 shifts and then leaving in a place where you're not really committed to trying to make better or improve or anything else, you're not engaging and committing in the community of the hospital emergency medicine. And I think we have to emphasize engaging in community as well.
So I want to throw something into that. And this was, Andy and I had talked about this before. I I think that we need to stop considering lifestyle a dirty word. And I know it's a brand of condoms, so it's easy to think like that. But um, the lifestyle idea, we actually took it and embraced it. We were known as the specialty. We are known as the specialty that plays hard and works hard. You're on, you're off, and that's great. And I have been home for my kids. I did have an actual family life, and I made it to the winter solstice concerts for my kids, which is horrible because those concerts were terrible. But the thing about our specialty is it is okay to talk about the fact that you can have everything. You can have a life and all that. And for ages, we didn't talk about it because we were in a position where we didn't have to, I think. And now
Well,
other
also
specialties have adjusted.
Yeah, I think you're 100% correct. And I think, again, sort of having learned a lot this week, having this conversation many times in different forums, if you think about how we being the dinosaur age that I'm at, how we were brought up, it was about put your nose to the grindstone, go forward, and that's what success was. You work harder, you get more, and the goal was to continue to grow like that. So the expectations were different. I think today, there are many more people in this generations are much less about that and more about how can I make my life better for me? And that's perfectly okay.
It's not bad.
It's again matching. It's matching.
They don't need to be mutually exclusive.
Correct.
And I think we need to tell the students that it's like, look, I still work, probably more out, probably, my work weeks are probably 60, 65 hours, probably because I forgot what I did for 25 of those hours, so I have to repeat them a second time to see what I actually was supposed to do.
It was finding work. That's the
Yeah.
hard part, getting to work.
But I think that, I think, Tom, to your point, I think we're telling students like, listen, where am I, outside the year, where am I happiest? I'm happiest when I'm sailing, right? So I know that, when we would do races on Thursday night, I knew to make sure that I had the luxury of making sure that my schedule on Thursday got me out of the hospital at a certain time, but I could get down to the boat and get to the start line. We had a guy on our team for the first time we raced about 25 years ago, said, oh, I'm a vascular short, I want to race with you guys. And we're like, okay. And I said to my buddy, I said, he'll be gone in a week. He lasted 2 weeks because every time you get down to the marina, the beep would go off or we'd get stuck in the OR. So I think it's okay to say, listen, you want to race? That's fine. You want to bike? That's great. You want to garden? You do that. You want to mountain climb? You can do mountain climb. But when you're taking care of patients, you're going to be doing something really cool, but you're also going to be able to have control over your life. If that's what you mean by lifestyle, then yeah, emergency medicine's got lifestyle.
Right.
Absolutely.
Perfect. Yeah.
But it's not in a pejorative term of like, I want to work very little, get paid a lot of money, and then not really care for my patients. That's not what emergency medicine lifestyle is.
That's up.
But here, other specialties have followed our model. I absolutely remember I was taking care of a bunch of sick patients. The surgeons were there. And my shift ended and I signed out and was going home. And the surgeon pulls me aside and said, you don't care about your patients. If you did, you would stay here till the end of the case or the CAT scan. I'm like, that's not my field. My field is to be intense and on and do what's right. And then trust my who comes on after me to continue that. And they back then they were upset with me and then they adopted it. And now when you're in the SICU and things are going bad, they go home too. And they're happier for it. And I think that it isn't a bad thing to adjust to this.
Yeah, but I think that's the message. I think we can control the narrative that you said. Lifestyle is not a dirty word.
Right.
Lifestyle is a way of saying you can take your kids to the doctors to get their immunizations. You can be there most of the time, at least not all the time, for the parent-teacher conferences.
Those were terrible too.
Yeah, well, yeah. I had to bring cash to pay the teacher off. But we can do those. You can do the things that you want to do and still be intensely involved on the professional side of your life in doing, basic, day-to-day clinical care, but then you can also do really cool things within the specialty of medicine and healthcare and public health and everything else. So you really, on some levels, it's one of the, you can almost have your cake and eat it too on a lot of levels in emergency medicine. And I think we've lost that.
I think also it's important for us to educate that there's such a wide range of opportunities career-wise. And I don't just mean specifics of what you do, but the environment in which you choose to work. And within that, you know, there's the what I would call the full academic, you know, life, where it's not so much work-life balance, it's work-life challenge. Because there's that, then there's the other side of the spectrum, what you're sort of referring to, Tom, which is much more about making a decision that you want to reprioritize your life. And that's okay. It's about giving people choices of what works for them. And there's no other field that offers the wide range of opportunities that emergency medicine does.
So when you combine that with what you just said about this generation, our
exactly
field
right.
really sets itself up
Yes,
to be
exactly right.
it should be as exciting as when we were going into it.
Yeah, I mean, but I do think that goes back to this recurrent theme. It almost seems like this is what seems to be distilling out of this conversation, which is all the things that we need to be sharing with the students that are coming into emergency medicine that we're not currently sharing. I think go back to, I think we're making the assumption they know. I don't think they know. I think on some levels, in a lot of places, we're kind of running uphill because there are people that are not necessarily speaking well of the emergency department and stuff like that. And I think we need to counter that with the reality of what they, you know, to counter what's being told to them, but more importantly, to make sure they understand the width and breadth of what we do. Because there's no way, I mean, you know, everybody says, oh, I want to be a neurosurgeon. I want to, you know, everybody's like, oh, I was going to be a neurosurgeon until the first time I went into the OR for 17 hours. And now I never want to be a neurosurgeon. So I think I think we also give medical students a little bit more credit for what they know and what they don't know. And I think it's okay to say, you don't know what you don't know. And part of us as a specialty and as educators, and everybody's in emergency medicine as an educator, right? We educate patients, everybody, medics, EMTs, it's always education. We need to educate them so they understand why this remains the best field in the house of medicine.
Yeah.
I mean, there's no doubt about it.
And there's one other aspect that I'm never really sure whether it's a positive or a negative, and I'd love your opinion on it, everybody's opinion on it, which is we're one of the very few fields where, as a student, you're essentially doing what the attending does, career-wise. In any other specialty, as a student, you're hanging out with residents. That's who your team is. And life of a resident in most every other field is incredibly different than what life is like as an attending in those fields. And I wonder how that really plays into decision-making by students when they're essentially saying, well, this is what an attending does all the time. And I just wonder, I really do wonder what that means in the decision-making process.
It could be a huge advantage if they realize it, or they just assume that the parts where they're not seeing the attending are wonderful and they're hoping for the future. I don't know how that plays out.
I don't either. And I've always wondered if that was part of this
That's a question.
decision.
Hey, Tom, are we supposed to, do we want to ask questions?
So I just want to summarize, and then we'll throw questions out. Essentially, what we've been talking about, the sort of how should we essentially brand ourselves. The t-shirts that I've come up with so far are save the world one patient at a time, because that crosses generation, the desire to make a difference. Everything you read about in medical school and a lot more, mostly because we're all terrible students and didn't finish our reading, but also because there's a lot of stuff out there. So you get that variety. And the last one was only TSA gets closer to their subjects.
No, I got one. I get one that says I'm with dummy.
So putting it out to our audience, what are your thoughts? How should we rebrand emergency medicine to this generation?
Oh, and don't all jump at once.
Hi, my name's Alexia. I might be the only one here in the generation in question. For context, I go to Rowan School of Osteopathic Medicine in New Jersey. I started in July 2020, so of the pandemic era, and that definitely impacted, I know, the rest of my student body's perception of a lot of fields, but also just our ability to experience clinically different specialties in terms of what we were able to do during first and second year in terms of reaching out to people to shadow and volunteer. So I definitely think that reaching out or getting first and second years now, that sort of clinical experience in the emergency room prior to third year would be very advantageous. I know currently at my school, our curriculum for third year does not allow for an emergency medicine rotation, which was to my detriment because I would have loved to experience it prior to going through all the slows and all that entire process. I'm not entirely sure if many other medical schools across the country are like that as well. But definitely if you can get that clinical experience earlier, even if it's just like offering your the medical schools that are associated with residency programs, offer those medical students like once a year if anyone wants to sign up for shifts to come down just to experience it once or twice during that first 2 years, I think could be very advantageous. I definitely had some of my peers during fourth year reach out to me who ultimately applied and matched an IM, who throughout the interview process or even before that, once they did our school's mandatory EM requirement in fourth year, they reached out to me and asked like, oh, I think I'm making a mistake. Like, how do I do EM? Like, is it even possible? Should I be trying for a combined program? And I definitely had to like
Told them they were all making a mistake,
Yeah.
right, Alessia?
No,
Good job.
I tried
Good job.
I tried to sway them. Ultimately, it was so late in the cycle. It was kind of a long shot for them. But I had people, definitely many of my peers, reach out to me and be like, I can't believe we're experiencing this now. I kind of wish I did it or switched or did some sort of combined program. So I definitely think that having that clinical experience earlier might have shaped the decision of many of my classmates.
So I'll offer a thought. This goes back years and well, a few years ago. I started off at a medical school that had a very early emergency medicine residency. Emergency medicine was not a required course. Yeah, what did we do? What we did was we started an emergency medicine club. And the emergency medicine club, on average, would get 40 to 50 first and second year students. Why? Because the internal medicine club would come and talk about the movement of phosphorus across the cellular membrane. They'd come to the emergency medicine club and we taught them how to draw blood, how to put an IV, how to read an EKG, how to put the leads on, how to suture. I mean, so you don't necessarily have to have, if you have to kind of work around the medical school because they don't have required rotation, you can do it. Because the thing that's most practical, that the students love about emergency medicine is it's a practically based specialty. So you can bring them to say, listen, everybody's gonna need to put in an IV, everybody's gonna need to draw blood, everybody's gonna need to know how to an EKG. But while you're teaching them how to do those things, you can grab their hearts and minds. The problem with schools that have the fourth year sub-I, the required fourth year experiences, if it's past November, December, they're nailed. They can't go back. So I think the earlier you can do it, if the school is going to validate it and make it part of the curriculum, that's great. But if not, then as EM docs, we're obligated to come up with a workaround.
Yeah, I 100% agree with that. And I think, being facetious, but the best way to recruit people into emergency medicine would take all the students and do a simulation where everybody's on a plane and somebody gets sick. And they ask for a doctor on the plane, and 6 doctors walk to the back of the plane and they each identify each other, and the emergency medicine doc is the one who's left behind and the rest go back to their seats.
I've definitely heard this joke before.
Yeah. Well, yeah, I know 6 doctors walk into a plane, but no, but
Pretty sure I lived that before.
yeah, we all have, right? And for many of us, that's why we went into medicine in the first place, is to take care of patients. So I think we need to do a better job of reinforcing that you are able to do everything, and everybody else will rely on us to do that. And that's a big sell.
That's a big sell. But I think that, you can listen, we're doing, I don't know, what are we doing here, Marion? This is a webinar, right? Or is this a Zoom?
This is a webinar. Yes, doctor.
Thank you.
This is on the internet, right? That's that newfangled thing.
This is the internet. There's a video
lot of
that will
tubes.
be able to play this
It's just
again.
bad. It's going to go away. But there's no reason that at your institution, who says the Department of Emergency Medicine or the EM residency or whoever the emergency medicine, the students who are EM bound, you can run a webinar.
Yeah.
You can have a webinar.
Yeah.
You can say, listen, to all the students in my school, we're going to have, and you can invite people, you can do it yourself, you can go cross town. You can have the conversation if you want to have the conversation. In today's market, it's so easy to do. So, it's like, you're right. And sooner or later, we got to grab their hearts and minds that, I mean, the problem with a lot of medical schools is they sometimes think that when you do these emergency medicine things, that we're out there kind of, hawking the specialty. We're like trying to sell the specialty. Well, I want to know what physician, no matter what specialty you do, shouldn't have a basic skill in taking care of a sick, unidentified, no lists, no this, no that, a sick patient that doesn't come in with a to-do list. What is wrong with learning how to take care of the undifferentiated patient? We teach a skill that nobody else in the house can teach, which, by the way, every doctor should have when they graduate. They should know how to do CPR. They should know how to open an airway. They should know how to, I mean, Tom's at a place where you guys all have to, your first year students all have to become EMTs. So it's out there. You just have to figure out ways to get around.
I think one of the other brilliant things I've heard, again, back to the fact that we have the skill set for physical diagnosis, is every med school has some sort of physical diagnosis class, right? Or some sort of, sorry?
All be taught by EM. That's the only people you should be
Should
teaching.
all be us, and that's going to be first and second year. That's going to be early. So, I'm grabbing some of the stuff going on where I am now in terms of trying to get the first years have to shadow with somebody. Emergency medicine oddly wasn't on the list of the group they were going to. So I made myself available to people, kind of through a back alley. And now I have people coming up that want to come and shadow in the emergency department as first and second years, because they have to check a box off on their thing anyway. Might as well be there.
Good point.
Any other thoughts out there?
Yeah, I think in gate, when they come down for shadowing, or, we have a third year, an M3 elective. But, get them engaged. The more they're engaged, the more they feel like they're contributing, the more they get to do, even if it's not, awesome stuff, just basic suturing. It's like such a thrill for them to be involved in actual clinical medicine and doing stuff, and being part of the team.
Again, I mean, you got to kind of know your audience, right?
Yeah.
I don't mean this to sound disrespectful or dismissive of medical students, but my God, they're easy to impress.
Yeah.
It doesn't take a lot to impress a medical, especially a first-year medical student.
Yeah.
So I mean,
I had a case of secondary syphilis the other day, and they were all excited about it. I don't know what.
Well, I also get excited about secondary syphilis, so I'm totally there.
Most said, right? By the way, most said, if you know syphilis, you know medicine. But that's another whole story. But I do think that there's ways that you can validate your importance to, and if nothing else, if by doing this early intervention into the early years of medical school, and again, to get away from the idea that we're out there trying to win the hearts and minds and get people to come to our specialty, if we just say we have an honest to God valuable product to teach every graduating medical student. If we do nothing else other than to get them to understand, listen, I don't want to do emergency medicine. I know what I want to do because I've done research in it. That's fine. But let them graduate from medical school with an understanding of the importance and the value of emergency medicine to them and their patients in the community. So if they go out and they were another specialty, but they still have respect for the emergency department, you've done a great public service. You don't have to catch every medical. We don't need 150 graduating medical students from every class to go into emergency medicine. We need the, what's that thing from the Marines? The few, the proud, right? We need the few, the best. That's who we need. And everybody else, just when they come down to the ER, know that, you may dislike us because we're admitting at the wrong. We never admit anybody to any service or ask for a consult at the right time, right?
Right.
It's always the wrong time.
Right. We never take work away from somebody. We only give them.
But what's interesting is, where do they show up at 2 o'clock in the morning when their mother is ill?
Yeah.
Who do they call? They don't call their private doc. They call the ER doc who they had a bitching session with 2 weeks ago about an admission and say, hey, my mom's sick. Will you take care of her, please? That's an incredible sign of respect to the specialty. And I think if we can get folks to understand that that is what we do for a living, then I don't care if they go to another specialty, but I want them to come down to the ER and say, I'm glad you guys are here.
I
don't really have a great suggestion as to how to rebrand or recruit more, but I do have a question for the group that I kind of wanted to pick your brains about. And that is, I think one of the major drivers for why we've had such a fallout and interest in emergency medicine is because the CMG's massive takeover of the field of emergency medicine in this country is being widely publicized in general media, as it should be, right? Like, the patients should know what they're getting into when they walk into whatever ER they go into. But along with that is the reality of how difficult that actually makes the working conditions. Many of us have the luxury of not working for a CMG, but we all know the reality of the job, or the reality, the state of the job, which is that more and more EDs in the country every day are being taken over by CMG, where some Yahoo, some 22-year-old MBA who's never stepped foot in your department is dictating how you should do your job when they have no idea what an EKG even looks like. And that is actually getting filtered out to medical students while they're still at the student stage, before they have a chance to really even explore the field of emergency medicine. Everything that everyone has discussed thus far, I totally agree with, and it's wonderful, but a lot of that is, I think is in a vacuum. Like, we've kind of been discussing it in a vacuum outside of the reality of what working in an ED in America in 2024 may be. So how do we kind of, how do we mitigate that message? How do we kind of assuage their fears of this?
Gordon, can I
Go ahead.
love the question.
Yeah.
And I think it fits into almost the same thing that Wally said a few minutes ago, which was, it's sort of easy to impress a medical student with simple knowledge stuff. The problem, Gordon, is that we understand what CMGs are and how that can affect our career and all that. Medical students do not. They are getting pieces of information. And every time a resident turns to me with a new set of initials, I always have to go, I'm sorry, what disease was that? And so I got my standard answer to residents who are worried about contract management groups is to refer back to one of my favorite people in emergency medicine, Paul Guinness, who worked for the people who wrote the company that was the rape of emergency medicine. And if you know the book, I'm sure many people here do, it describes exactly what you're talking about, MBAs making all the money and the physicians doing the work, and it makes it sound really terrible. And if you ask Paul about it, he said, I loved working there because all of that stuff happened well above my head. I got paid exactly what they said that I was going to get paid. I was in the geography that I wanted to be in. And although everything in that book is probably right, I was happy in that job. And so,
Yeah, but
wait, let me just finish the
Okay.
thought, which is so I think that there are two things. One is buyer beware. Every job has the potential to go bad on you, and we are not as protected as we probably should be. And I think your concerns about contract management are totally real. But the people who get paid exactly what they are supposed to get paid in the areas where they're supposed to get paid that, they don't necessarily feel as awful as hearing about it from outside. It's the contract management groups that all of a sudden shut down an ED or throw out the academic group. That's a huge problem. And I don't mean to undermine that, but I think that this is either by giving medical students more information so that they understand it, or by realizing that a lot of this stuff is well above anything they need to worry about for 4 years.
Right.
3
And
years.
I'm gonna come at it from another point of view, which is, yeah, you're right. You worry about CMGs, you worry about the commoditization of medicine. And look, the numbers are clear, right? KKR and BlackRock own about 44% of all of the EM independent practices across the country, right? BlackRock manages assets of $10 trillion. Not a billion, trillion. All right. So in terms of the overall aspect of medicine versus KKR and BlackRock, we're David,
Kind.
they're Goliath.
Yeah.
And that's just the way it is.
Yeah.
And I had a buddy of mine who works for BlackRock, called me about 6 months ago, and he said, hey, well, I got some questions for you. He said, so we're gonna, we're delving in, and we're really interested in buying, we're gonna really take over radiology. We're just the tip of the iceberg. It's only going to be a matter of time before radiology, anesthesiology is already being across the country. There are multiple groups that are managed by asset management corporations.
Yeah, dermatology, big.
Big, right?
Ophthalmology, huge.
Right. So
Yeah.
I'm thinking to your question of how do we tell medical students, well, this is awful in emergency medicine. No, it's not awful in emergency medicine. It's awful for medicine.
Yeah.
And we need to have that conversation of like, yeah, you're not going to get away from it right now, but we need to come together as a profession and figure out a way to get out. You're not going to get them to walk away from emergency medicine because we're not going to get them to walk away. The question could be how long before it takes over everything, and I think that's what medical students have to be aware of. Don't scapegoat emergency medicine like we're no different than anybody else.
In fact, even more so. That's 100% correct. And I was just going to
Yeah.
say that, which is this issue is not new. This issue has been around for 60 years, really since the concept of emergency medicine, even before we became a specialty. We are actually one of the last fields to be drawn into this. Most of other medicine has been dealing with it for many, many, many more years than we have. It has been part of our field, and especially, and Tom referred to the Bible that we all read when we were joining emergency medicine 40 years ago. But we've been really on the tiptoe end of this in our own field. It's only been in the last 3 to 5 years where it's become much more oblivious, much more obvious, much
Right.
more in our face,
Right.
because it exploded, because all of a sudden they decided it was worth getting into it in emergency medicine. The reality is we're actually way behind all the other
Right.
fields who have been so much more embedded in this than we are. And to Wally's point, it is unfortunately the future of medicine that we, again, goes back to what I said earlier, need to be part of driving. And in emergency medicine, we're going to have more opportunity to drive that than in any other field.
Right. So I think the flip side to the students say, listen, you're right. That's a great question, but this is the bigger question than emergency medicine.
Correct.
Let's talk about medicine as a profession as a whole, and let this then you're really educating the student as to never mind. I'm graduating and going into a profession that has this on the horizon. It's storm clouds, right? But we got to make sure that we don't feel get them to think that we're in this all by ourselves. I mean,
What percent of nephrology do you think is it's got to be
DaVita.
Got to be 80% of the field.
DaVita is one guy. The same thing that happened with an urgent care group in New York City with CityMD. CityMD and DaVita were bought out by a venture capitalist group years ago. And they've got them all over the country. So that every doc who's working for this DaVita nephrology group is working for an asset management company.
Yeah.
So, and it's only a matter of time before it just. So we need to let our medical students know that this is the reality of the profession. It's not specialty specific. So I think I would, if that student come to you and they ask you that question, I would ask them to expand their horizon and have a greater conversation around the threat to medicine and more, not so much the threat to medicine, because I think emergency medicine is patient-based. I think the question is, what is the threat to our patients? Right? And I think that I don't think it takes it out of the medical student's mindset, but it may force them to expand what they're worried about and say, well, gee, so I'm gonna be like my buddies. I mean, I live outside of New York City, and there were in Westchester County, there were probably 7 or 8 or 9 huge internal medicine groups and had been around for 30 years. I mean, big groups all owned by the physicians, right? Not one of them currently exists in the current form. They're all owned. They've all been sold and owned. So, you're right. But it is the environment in which we now live.
And realistically, we are incredibly well positioned in the, I remember Steve Safe at Jacoby walking around handing out lunch trays. And one of the things he said, and I was a medical student at the time, was in emergency medicine, you can always be an advocate for the patient. So he was advocating to feed the people who were hungry, which was a beautiful thought. But the reality is, going forward, we are in a unique position to advocate for humanity approaching medicine at large, which is why you see emergency physicians running for political office, which is why you see us getting involved in other levels of advocacy, because you're right, the house of medicine is broken, and we just happen to be the people who are able to negotiate and talk and communicate with a lot of people. So
Again,
I
I think
agree.
one of the issues is I don't hear our colleagues in the other specialties talking about it, but I hear us talking about emergency medicine. Same thing. Medical students talk about burnout. I think it's because emergency medicine physicians aren't afraid to talk about those things. I think other specialties, other specialties are afraid. So I think on some level, we're kind of hoisted on our own petard in that we look inside the house when things are broken. We don't pull the curtains down and say, don't look inside the house. We're happy to say we got a problem, but more importantly, because we're proactive and we're aggressive, the answer is we want to know about it because we want to fix it.
And we have a flexibility of skill set where we can take on a different challenge if the current challenge isn't what we want to be in.
Right.
I am looking at the time. I would love for this to go on for another 3 hours. I can assure that this conversation will continue at some bar in New Orleans in a couple weeks. So feel
I don't
free
think so,
to.
Mary Ann. I think we've solved all the problems with this one phone call. I don't see any
And a few
issues going
t-shirts.
forward. I think this is in trouble. I think we're just done. We don't even need Cord next week. We're done.
Yeah, I think next one is we figure out why the sky is blue and we're all set.
Any additional last thoughts, Dr. Carter, Dr. Ulrich, Dr. Perera?
No, I'll see you all in New Orleans.
Not
All
me.
right. You're not going?
I'm not invited.
Andy's not allowed.
Again, another state line, something about another state line, and I don't know what it's about.
TSA will not allow him off on the plane with a New Orleans plane ticket.
Something
No,
about
no, no, no.
state-
There's a difference between not being invited and being uninvited, Andy. It
Yeah,
sounds like you're
yeah.
going to the second one.
Something about state lines and not allowed.
Yeah, I don't know, whatever it is. Okay. Lots of allegations, nothing was ever leveled to
Right,
indictment or
exactly right,
conviction, so
right.
we're good. All right, guys.
I
Thank
really
you
want to
very
thank
much.
our speakers who are esteemed leaders in the field. I want to thank everybody else for jumping in with thoughts and questions.
You
This
didn't
was
say the
a
total
really
number of
great
years.
session.
You didn't
Sorry?
say the total number of years between the three of us in emergency medicine.
I'm
I
pretty
was
sure I
waiting
can't
for
count that high.
I was
You-
waiting for that.
You need Roman numerals.
Yeah.
Yeah. Tom and I are both 28 years as attendings. Andy, you got what?
33?
33, 28. Wally, should we even touch that?
Well, if you include my paramedic time, it's well over 40.
All right, I'm gonna give it to 40. So that's 60, 70, 81 years between Tom, Wally, and Andy.
That's
81?
we can
Oh,
beat that.
Total experience is 81. If you toss me in, since I never shut up, that brought us over 100.
Right, and
Man,
then you divide by the maturity age, and then we're down to 6.
I don't want to say anything, but man, do we look good for 100?
Thank
Looking
you all
great,
very much.
guys.
Very
Oh,
inspiring
thank
talk.
you.
I
Thank
really
you.
It's a
appreciate the
pleasure.
time.
Thank you.
All right, guys, thank you very much. And thank you for Cord sponsoring this for us, of
Yeah,
course.
absolutely.
Great job.
This was
Thank
a
you.
great conversation. Thank
Yeah,
you
thanks,
very much.
everybody.
Right.
Thank you.
Take care, guys.